Hi, and welcome everyone to our webinar today. We are leveraging data for healthcare excellence. And today we are going to do so by unpacking CMS updates on health equity, social determinants of health, and overall Part D measures. So welcome. My name is Emily Indris, and I'm the Vice President of Pharmacy with Innovaccer. And I am extremely proud and humbled to moderate this insightful webinar for you today. And we're going to hear from our panel of industry experts as they help us understand the importance of data to enable navigation of all the CMS changes, including health equity, social determinants of health, and overall just Part D changes that are coming down the pike. And we really find ourselves in this very interesting intersection of healthcare where we've seen significant evolution in how CMS thinks about the balance of quality and cost and how these two really important pillars impact each other moving forward. So our aim of this conversation today is to help our audience understand a bit more around the why behind some of these latest CMS updates and really to share thoughts and inspiration on how to find scalable success in this new environment that is just packed full of change. So let's dig in. And with this, we're going to meet our panelists for today. So it's my privilege to introduce you to these three industry thought leaders. And first, I'd like to introduce you to Kara Broik. She is the Vice President of Clinical Quality for Longevity Health Plan. Kara has been navigating quality for health plans for decades and is passionate about solving really some of the complex healthcare issues that we face. So, Kara, welcome to our conversation. We'd love for you to introduce yourself and tell us a little bit more about the perspective that you're going to bring to our chat here today.
Thank you very much, Emily. Yes, I currently I'm the Vice President of Quality at Longevity Health Plan, which is an integrated special needs plan. So all of our members are in a skilled nursing facility. Prior to this, I was over quality. Really, it was Medicare Advantage, Medicare cost, DSNPs, as well as commercial and Medicaid and exchange. So wide breadth of experience with quality. And so I'll be bringing both perspectives from where I currently am, as well as my previous experience.
Awesome. Looking forward to it. Thank you, Kara. Up next, I am pleased to introduce Nate Lucina from the Rex Wallace Consulting Company. Nate is the Chief Strategy Officer working with very matrixed organizations to build strategies for success in quality programs, and in particular, those within the STARS realm. Nate, if you don't mind introducing yourself and telling us a little bit more about you and your perspective on our conversation today.
Yeah, absolutely. Thank you. And thanks for having me. So like Emily said, the strategy officer for Rex Wallace Consulting, we're a quality improvement and organizational engagement consulting firm. We work with plans across the country to really look at their entire quality improvement program and figure out what the gaps are that are preventing them from achieving their goals. Before that, I spent almost 7 years at Centene Corporation in enterprise roles. And I started out in analytics and data science and then kind of shifted more into the quality strategy and operations space. And so from wearing both of those hats, those are the perspectives that I definitely bring to the conversation today. And a true burning passion for health equity is the lens through which we need to view all of our quality improvement work. So thanks for having me. Excited for the conversation.
Thanks for joining. All right, last but not least, we are joined today by Dr. Anil Jain. He serves as our Chief Innovation Officer here at Innovaccer. And Dr. Jain has focused his career on understanding the intersection of clinical practice and research with informatics, engineering, data, and technology. So Dr. Jain, please, if you don't mind introducing yourself, telling us a little bit more about your perspective in our conversation today too.
Well, thank you, Emily, and thanks, Nate and Kara, for joining us on this. So, as you said, I'm the Chief Innovation Officer of Innovaccer. What that means is I get to have a little bit of fun with our teams, really thinking through the art of the possible, especially the emerging topics that are of most interest. I've been at Innovaccer for nearly 3 years, and prior to that, spent 5.5 years or so at IBM Watson Health, really focused on some of the challenges that we had over there. Became an IBMer after a company I co-founded called Explorus was acquired. I had spun that company out of the Cleveland Clinic, where I was a senior IT executive and a clinical informaticist and an internal medicine practitioner, which we'll probably get into in a little bit. My background in this conversation is really going to be one around real world experience around quality, real world experience around the good, the bad, and the ugly of technology and what it might mean for the topics that we're going to be talking about today. So I'm really looking forward to this conversation.
Fantastic. Thank you so much for joining us today. We're definitely looking forward to this chat too. So without further ado, we're just going to dig on in. So first, we're going to kind of start here and tee up our conversation with something that reminds me of summer. Summer is basically here, right? And this notion of being on a roller coaster, I think speaks to many of us. So we've seen this roller coaster kind of been a thing from CMS, if you will. We started with keeping members healthy when we started on this adventure and journey together, but that was really more at a care coordination level. Then as we continued on our adventure here, we got to keeping members happy and focusing a lot on member experience. We saw CMS not only triple, but 5x some customer experience quality measures around timeliness to respond and just, how happy are customers with the health plan that they've selected. And here we're on probably one of the largest hills in this roller coaster, if you will, and that is keeping, going back really to quality, but it's not just keeping members healthy, it's keeping each member healthy and thinking about that through the lens of health equity. So this time around, it looks a little bit different than when we experienced quality previously, as we've added in social determinants of health, health equity, and again, all while managing cost very differently too, and we'll dive into that. So Nate, I would like to turn the first question over to you, if you don't mind, as you've been leading and advising in this space for years. So as you're working with several different health plans in the marketplace, one, does this roller coaster resonate with you and your clients? And then maybe if you could share with us a little bit more about how health plans should be thinking high level around navigating some change management, really as our quality focus expands.
Yeah, it's interesting. I was thinking about this before joining the webinar. I've been doing STARS for almost 10 years now, which seems nuts to say. This is kind of a second career for me. So the roller coaster I've been on this roller coaster ride for 9 years, and it is relentless, as those of you who work in STARS know. So the fact that we're on a roller coaster, not that new, but the roller coaster continues to sort of evolve and like push us into new directions, right? So I think health plans and sort of vendors and providers that support those health plans are absolutely feeling the roller coaster, especially the whiplash around kind of this really major shift from care coordination and prevention into member experience in terms of how the measures are weighted within stars, and kind of how you get to that 4-star mark and then achieve your quality bonus payments. So it's been interesting to see CMS just turn right around only a couple of years after making that huge change and say, just kidding, actually, we're going to go back. I totally agree with this, though, right? Because folks who have been advocating for this approach have been saying it shouldn't necessarily be either or. These are equally important things, and one begets the other. More engaged and happier members are more loyal. They're going to be have a more stable relationship with the plan and their provider. That makes a lot of things about delivering the highest quality care possible and helping members achieve their highest health much easier and more efficient, right? And adding health equity and SDoH into the mix is also really interesting. So, what I'll say is I came up at a company that was predominantly Medicaid, and then got into the Medicare business. And for those of you who are supporting both of those lines of business, you know that health equity has been the true sort of capstone of all the activities on the Medicaid side of the house for a long time. And certainly, Kara, you've worked with D-SNPs for years, right? This is a touchstone, right? This is how we get quality improvement work done on the SNP side of the house. So bringing that more formally into STARS is really CMS's attempt to acknowledge some of the things that folks in the industry have been telling them in the comments, which is saying that there are plans who are providing coverage to a high density of these very complex members, and the incentive structure is really not there to support them in truly focusing comprehensively on social determinants of health. It's also interesting, kind of the thing you said about keeping each member healthy, right? This focus, population health is still there, right? We still have to do population health management and manage the cost, but getting really surgical about how we do that and saying that if we deliver care holistically to the member, not just the clinical side of the care, not even necessarily just the member experience, but holistically, what is this member facing that is determining whether they have the energy and the wherewithal to truly focus on other aspects of their clinical care that we've been sort of bugging them to engage with, truly treating that member holistically in terms of their social barriers, their economic conditions. That's really where CMS wants us to go, and that's where we should go if we truly are going to scale sort of the cost-saving measures and the highest quality care possible across the entire MA membership when it comes to quality.
Yeah, I think you bring up several really key items there, and I'm going to focus in on one or two here for just a second. And I think the point that you made, Nate, around member experience and loyalty, and as we think about this shift to keeping each member healthy, and what does that individualized personal healthcare journey look like? You're right, like this is just a synergistic way of kind of bringing things back full circle, so it definitely starts to make a little bit more sense, certainly when you put it that way. So if I take another point that you were making, right, as we think about shifting from population health management, we're really not shifting away from it. We're just perhaps enhancing our focus on that to be really focused on individualized member healthcare. And so when we talk about this, we really have to think about what does that approach look like for each individual person, meeting that member or patient where they need to be met. And that may start to feel like a 1 + 1, as you see here on the screen, is not 2, it's like 10, and potentially maybe a bit overwhelming. So Kara, I'd really like to turn it over to you at this point. As our colleague here in the quality space, would love to understand from your perspective and the health plan's perspective, what does this refocus mean for you, and how are you finding a pathway that is scalable and feasible to meet each member's individual needs?
Thank you. Yeah, the refocus for me personally is exciting. This has been something that's been going on for years. I remember years ago, before I was even in leadership, I was trying to help this member get a mammogram, and she was homeless, living in a car. And you know what? Getting a mammogram was not her top priority, and there was nothing I could do at that time many years ago. But now we have different benefits we can offer. We can, try and get them into housing. There's all kinds of things that health plans are able to do now that years ago we were not even remotely thinking about. All we thought about was that mammogram number. Then we switched from that, these individual member numbers, to a population health approach. Okay, so then everyone was focused on population health and looking at our entire population, but we still didn't completely forget about the member, but the only thing we were looking at on that member was gaps in care. So had they had their mammogram, colonoscopy, etc., we really were not taking a holistic view of that member. And we've been doing it in Medicaid for a while, but now in Medicare, we are being told we need to take that total view of the member and incorporate all of the things around that member. So looking at their SDoH, looking at their gaps in care, looking at their risk scores, looking, just their support system. Everything needs to be considered when you're dealing with that member. So what is the biggest issue we have as we make this shift? For me, it's data. I actually thought that coming to Longevity Health Plan would be super easy. I'm going to have all the data I need all right there at hand because all of our members are in a skilled nursing facility and we have our own nurse practitioners taking care of those members and we have our own electronic medical record. This is going to be a cinch. I can tell you it's not a cinch. So really the need to drive, we need the data to be able to understand the member, to be able to create the interventions to help the member.
Yeah, Kara, thank you for that. I think it's so important. First and foremost, I think all of us, as you've had an opportunity to practice, whether it's at a clinical level within healthcare, operations, et cetera, we all have that one experience that tends to drive passion for why we do what we do here in the quality space. So first, thanks for sharing your story there around the homeless individual with the mammogram. I can think of several other like stories like that, but again, I think it drives the passion that we're seeing and change, which is really important here too. So you left us with a really important kind of tool and tip there, and that's around the data. I mean, interesting to hear you say you thought that you had found the nirvana of all data, all with under one umbrella, one suite, one system there, but there are still some opportunities to think about it differently and some gaps there. So appreciate those insights for sure. All right, so we've established things are changing and that's okay. We're going to figure out how to deal with change management. The ask of CMS here is additive. So as Nate kindly said to us the other day, we're going to need to walk and chew gum at the same time, and having tools and support is going to be really critical for our success. So where are we going to get started? How do we start to peel back the layers of this a little bit? And kindly, CMS has outlined a stepwise approach for us. And for this refocus on quality, it starts with priority one, and that's prioritizing data. We very quickly move into this analysis of data, then we build solutions based upon those assessments, and we ultimately end up with this goal of proven healthcare equity and quality at that individual member level that we've talked about. So I don't know about you all, but this feels a little bit daunting to me. And when we think about really big, heavy items like this, I think as a best practice, we should always take a step back and think about the why, and then work towards understanding solutioning and what that's going to look like. So Dr. Jane, I'd like to kind of call on you next here, as you've been practicing, as you had mentioned to us, since the paper days in the clinical and informatics space. We would love if you could help us first kind of understand more of the why behind this new approach. And then Nate and Kara will start to dig into a little bit of the solutioning behind that.
Yeah, it's a great question, Emily. So yeah, I did start practicing during the paper days, where much of the information I needed about each patient was simply the most important information was right in the front of the chart, if you could actually find the chart. So no one is suggesting that electronic health records haven't changed things, but that's just one data source that we really need to tap into to really understand what's happening. And if you think about that roller coaster and the sort of the focus of the population and now the individual, I think of the triple aim or even the quadruple aim that we've all been thinking about in healthcare, where you really don't get a good sense of the individual without bringing all that disparate data together. And so it's not a surprise at all that the first priority is to bring all that information together in a standardized way so that we can understand race, ethnicity, and language. We can't offer folks the appropriate treatments without that. Now, we also need to take a step back. What do we mean by health equity? We mean that everyone has an opportunity to be healthy. It's not that everyone has the exact same outcomes. That would be amazing if we can get each and every member to be perfectly healthy. But let's start with just making sure we all are giving people access, which means we need to identify what the barriers they have to that access, which means we need the data to go along with it. So we know that there has been a long history, and the data bears this out, the data that Nate and Kara have looked at, I'm sure, that we have had populations of individuals that have not had equitable access to care. And we will use those data, unfortunately, to train models that then just propagate the issues. So I think CMS, CMMI, and others who have been staring at this problem for a while were absolutely right in focusing on how do we all engineer solutions and delivery models and reimbursement models in which we are incentivized to collect the right data, to prioritize the right care, and to be able to give each and every single member of the opportunity to be healthy and take some of those barriers away, like the social determinants such as income, education, transportation, food insecurity, all those things that we know about. So I think the ability for us to start with why are we doing this is fairly self-evident. There's an entire group of individuals that are being left behind when it comes to the way we deliver care. And I think this is a way for us to refocus our energies on bringing that together. We also know, and when I was in primary care and I practiced in the inner city, many of my patients would fit into this paradigm of having sort of vulnerabilities when it comes to their social determinants. I knew that it would be more expensive to take care of certain individuals than not. So the fact that this is being built in to help us ensure that the reimbursements are relative to the amount of effort that's being put in is right on. That's why we have Z codes. That's why the RAF score is going to be impacted by social determinants and so on. So it all fits together, but it starts with incredible access to data and the analytics that go along with it. And then we can start having a fair chance to provide health equity.
I think you characterized that so incredibly well, Dr. Jane. And you're right, this is an opportunity for everyone to have access to care and healthcare. It's not ensuring that everyone has the same outcome. So Nate, as you think about that, thinking about some of your clients that you're advising at this point in time, and maybe how daunting this perhaps feels, so we can get behind the mission, understanding the why. How quickly do we get started? Where do we get started? How would you advise on digging into this?
Yeah, so unfortunately, if you haven't started, I would say you should have started yesterday, but that's okay because we still have today and we still have tomorrow, right? So the short answer is ASAP if you haven't already started this. And I want to double click on a couple of things that Dr. Jane said. Data is absolutely the foundation for all the rest of these priorities. If you're missing data, and that data is more likely to be missing in the groups that you're trying to help, where you need to identify these barriers, then your ability to do priority 2, 3, 4, and 5 in ways that actually promote equity as opposed to sort of misidentifying the problem is going to be really difficult to do that. And one of the other issues about just going out and collecting the data is we're already over surveying our beneficiaries, right? We're asking them for things all the time. Unfortunately, a lot of these new measures are going to require us to go and ask them for more things and things that are extremely sensitive, things that a lot of the people who experience social barriers are reticent to share with healthcare payers, with vendors, less so with their doctors, but sometimes even with their doctors. And so to truly get this data in a way that allows us to act at scale and in a timely way, it's going to take everybody coming together to reaffirm trust in communities in the healthcare system. And one way you do that is by taking the data and then acting with it, right? Which I think is what Dr. Jane was getting at. We can't just collect the data and then say, okay, we've submitted our stratified rates to NCQA and we only have 10% missing data points, right? That's not the goal here. I understand we have to start somewhere, but please, everybody, remember that is not the goal. The goal is that you have that data so that you can help the population by delivering care how each member in that population needs it to improve the likelihood of an optimal outcome. So I just wanted to kind of back up and double click on that. And then also say that while we're waiting to collect the data, because this is going to be very difficult to do, we can't wait on the rest of these things. So Emily, to your point, yes, we have to walk and chew gum. At the same time, we also have to spin a basketball on our fingertip and do all manner of other things to get all of this done. but do the best that you can with the data that you have, while we as an industry are coming together to figure out how to provide the most solid foundation and priority one that we can.
And I appreciate the basketball spinning as well there. Yes, a lot to do, and I hear you loud and clear. I think our audience does as well. We have to get started somewhere with what we have access to. But the notion of community that you brought forward here, Nate, I think is incredibly important, and something that certainly, bringing a pharmacy perspective perhaps to this conversation. Pharmacy is a huge piece of a patient's community, a trusted source. And how do you then further connect pharmacies, physicians, and the member or patient all back together? And I think that's exactly what you are articulating, and where we see perhaps the most challenge, but also opportunity. So really excited to think about bringing a sense of community and trust back into the ecosystem. Appreciate that. Kara, what are your thoughts here? How do we get started? How do we walk, talk, chew gum, and spin basketballs?
So one of the easiest ways to get started is to look at the data that you already have, and you may need to modify it some. So think about the required HRA. Okay, so we have to do this HRA, and CMS has told us what needs to be included in there, but they haven't told us that this is the HRA we have to use. So take that HRA and extract the data that you can get out of it and utilize it in all of your analysis. But if you're missing a piece of data, add it. Add those questions to the HRA. It's at least a starting point for you. You have the tool, make the most of it. At one of my previous health plans, we had the HRA and the data didn't go anywhere. It just sat there. I couldn't actually extract data out of that HRA. Luckily, now at Longevity, we are able to get that data out of the HRA because it's done in our electronic medical record. But it's still not complete. It's still not everything that I need to be able to do everything that we need to do as we move forward here. So, start with what you have. Also, Z codes. I know in my previous health plan, we had difficulty getting providers to bill with Z codes. And the reasons that I frequently got was because we don't have any services to offer them. So if we ask the question and they answer that they have an issue, I have nothing to help them. So my team was putting together stuff to give the providers for talking points, like here's the local food bank, here's, all of those types of things. But continue to promote the billing with Z codes, because the more of those that we can get, as Nate mentioned, our members tend to be more open with their providers, but not always, but more open with their providers than their health plan. So if we can get that information from the providers, it will really help us. But really utilizing the data that we have. Unfortunately, the data that we have is in multiple different sources. So somehow we have to get to that one picture view to be able to actually accomplish this.
Okay, I think that makes great sense, and something that I want to go back to that you mentioned here, and I think it's incredibly inspiring, right? That we've been given this kind of template or foundation to consider using from an HRA perspective, just as one use case example here, right? But what I heard you say, Kara, is that that's just the check the box action, but the call to action is not just to check the box anymore, right? So what other data sources do you need? How do we need to think about sourcing other data, other pieces of information to bring in that story? So we get to be a bit creative when we think about operationalizing some of these different strategies to succeed with all of the changes that we see coming. So I appreciate that insight. Thanks, team. Okay. So we said we were going to talk about all the changes. So we've talked a lot about health equity. There's this other side of the equation that's cost equity, and we have to do all of this simultaneously. So we've got this, right? Here are some other industry items that are impacting our strategies at a health plan and quality perspective today. We've got IRA changes, health equity index awards, and incentives, the ACO primary care flex model, the Medicare prescription payment plan and copay smoothing, prospective quality management. There is a lot going on at this point in time, in addition to what we have already discussed on this webinar today. So at this point, I want to take a brief pause here, thinking about these additional initiatives that CMS has put on our plates, again, to bring affordable healthcare as an opportunity to everyone. What are the programs that you in the audience are most excited about? You can use the examples we displayed on the slide before, put in your own examples here. This is totally up to you. There's a link in the chat box for this webinar that you can click on and go to complete the poll. If you would like to scan the QR code, you can do that as well to submit your answers, but we'll give our audience here just a couple of minutes to provide us, what gets you most excited when you think about bringing all of these changes together? Okay, we've got some folks typing. We appreciate it. We'll give everyone a few minutes here. So far, it looks like we're doubling down on the Health Equity Index Award and adjustments. We'll look forward to hearing some thoughts from our panelists today. All right. Okay. I see a couple of other people typing, so we'll give it just another second here. We've seen a few different items pop up, which is great. So we all are focusing in different ways. Or we're excited about different things, which is awesome. Okay. We'll get this last one to come on in here, and then all right. All right. We can go ahead and close the poll down, but I'm going to leave this slide up here for some inspiration. And first, I think, Nate, I'll turn it back over to you. Are you surprised by any of the things that are making our audience members most excited about all of the change that we're navigating? Do any of these surprise you? What are your thoughts?
I'm happy that people identified the HEI as something to be excited about, because typically we're hearing folks be a little bit anxious about it, and some of the quality changes. I mean, no big surprises here. I think, pairing the health equity index, along with making sure that donut hole goes away, right, for these members, so that they can predict their costs when they're going to get their medications. That is absolutely going to be disproportionately impacting the really complex members that have social determinants of health that need to be addressed for them to be able to, again, achieve their highest level of health. When we talk about the health equity index coming online, and the reward factor, the historic reward factor going away within the star rating system, for those of you that are working in health plans that have a really high percentage of these members with social risk factors, which I don't want to go down the rabbit hole of how dual eligibility, low income subsidy, and disability is not the entire universe of health equity work. That's probably a whole different webinar that we could spend an hour on. But using that as the impetus, right, as the opportunity to truly innovate around what you're able to deliver to members around their social needs, using VBID and other programs through Medicare to make sure that you're being as innovative as possible with those dollars and what you're giving the members to help alleviate, right, some of these non-medical drivers of health that are true barriers to them. For instance, getting a mammogram, as Kara was saying, or keeping their chronic conditions under control, or staying out of the hospital. So really, again, using this as an opportunity, facing the challenge head on, as opposed to using it as something to be anxious about. Although I totally understand that reaction. I think we'll give you a leg up here. And then, the community behavioral health centers, I will not pretend to be an expert in that aspect of it. But when we think about cost containment and the things that truly are driving costs that might be not as represented within the incentive structure of high quality performance, behavioral health, severe mental illness, it shoots right up, to the top of the list, right? Unaddressed mental health conditions. We can put Medicaid over here for a second, but thinking about Medicare, there are really very few behavioral health measures within the STAR rating system. And what that can lead to, not always, right? Some health plans are really good about this comprehensive delivery, but what that can lead to is less of a focus on treating the behavioral health side of your member and focusing a little more heavily on the physical health and the member satisfaction. Any sort of program, care delivery structure that helps you do both for those members that need it is ultimately, something that you should invest in and figure out for your membership, because it's the right thing to do, but can also be a huge cost driver.
Yes, thank you. I think you brought up quite a few really good points there. And I agree. It's great to see that people are excited and perhaps not anxious about the HEI. That's fantastic. And you mentioned something there, Nate, that Dr. Jana, I'm hopeful that you can kind of weigh in here and from your perspective as the innovation officer here at Innovacer, thinking you have, this opportunity to use some funding in an innovative way to, again, get after the goal here of meeting each patient or member where they need to be met. Do any of these poll answers surprise you, Dr. Jane? And can you maybe lean into a little bit more, Nate's comments there around the opportunity to innovate when you think about making this work for the Health Equity Index?
Sure, Emily. Yeah, and nothing on the screen surprises me. And it takes us back to the analogy of the roller coaster. If you think about the roller coaster, the typical roller coaster as having multiple peaks and multiple valleys, and you're turning and twisting in different directions, perhaps a loop-de-loop, and all sorts of things. That different aspects of what is happening in the transformation are gonna excite different people, and perhaps even make other people nervous about things. So no surprise at all on this. And in fact, it takes us back to some of the models that many of us had been looking at around integrated care, where you do bring in behavioral health together, for example, with the traditional medical care that we typically think about, along with the social determinants of health around the impacts that they might have. So from an innovation point of view, there's a couple quick things that come to mind. Our investment, for example, at Innovacer in linking together the social determinants of health, bringing together consumer data in a privacy-preserving way, and not in a creepy way, but really understanding what others might know about individuals and their households, bringing that together and then linking that to the community benefit organizations so that we can make the ability to refer a patient for food insecurity or for transportation insecurity to the localized versions of them as quickly as possible. At the end of the day, healthcare is fairly local. That's probably one of the reasons why you can't have a single one-size-fits-all HRA across every member in the U.S. And there is some liberty at the local level. So innovation can happen at the local level. And then the other opportunity for us as Innovaccer is when we do innovate and we do see results that either hit the quadruple aim incredibly well, like the patient experience, like the ability for the quality improvement to resonate, or the total cost of care to drop, or the experience that providers themselves have when they're providing that care. We can then propagate that and convert these micro innovations, if you will, into macro projects. I think the ability to have relatively wide guardrails around what can and cannot be done gives folks like Kara and Nate and myself and all of us really an opportunity to say, how can we be creative in the way we innovate? Because one size fits all is not going to work in every community. I think the other thing that was a little bit surprising on this survey that I didn't see is some of the challenges and the barriers that providers have in understanding how to deliver integrated care. I went to medical school 30 years back, so things have certainly changed, but I will venture to bet that most medical students and most folks who go through a clinical program are taught more about the physiology of the way our body works than the real importance of community benefit organizations in managing the care of our patients. So I didn't see provider behaviors. I didn't see training and education, both at the provider level, but also understanding about how things from a health equity point of view are going to change the way we practice and the way we might approach patients and members in helping them understand what their responsibility and their roles are in keeping themselves as healthy, working alongside the clinical teams. But otherwise, I think this is an opportunity for us to say what is our responsibility as a data platform helping organizations transform care, as opposed to what is the responsibility of our partners out there, like Kara and others, in order for them to be able to be creative in their innovation.
I appreciate that response, Dr. Jane. I think I really love how you characterize that some micro innovations to lead into macro innovations, right? And that's the theme that we've been hearing all along here. We have to get started somewhere. We have to use the data that we have on hand. And it's about individual care, not just population level care. So we have to really dig in and think at that micro level, and perhaps having access to data will allow us to be able to innovate in that way. Kara, I'm going to lean in for you here. And any surprises? Are these the same things that excite you on the day to day and thinking about all of the changes that are coming down the road here?
Yeah, I would have actually had a difficult time answering the poll and picking just one. So I am very excited about all of this. HEI is near and dear to my heart. I am a nurse still, and just that whole aspect of providing care and making sure that we are meeting the members where they are. One thing that really surprised me when I came to Longevity Health was I've never worked in a skilled nursing facility, and besides when I was in nursing school. And so I hadn't had, that experience and understanding your population, and even state by state, our populations are very different. But in certain states and in certain nursing homes, we offer a music therapy program. And I was like, why are we offering music therapy? Okay, there's other things we should be doing. Well, no. For some reason, with members with Alzheimer's or any kind of dementia, music, they still can connect to it. And so it helps with that loneliness. So would I ever have come up with a supplemental benefit that would help with music therapy? Probably not. But looking at the data, I can see we have a very large volume of members with dementia. And so how do we meet them where they are? It's a very different thing. How do you meet that homeless woman where she is, living out of a car, and trying to get her the help that she needs in order to take care of her preventive care and be healthy? So really, no matter which item you're most excited about, you need to have the data behind it to drive it, and then you can be creative and innovative in what in your solutions.
Fantastic. Definitely agree. And let's take that notion of data and kind of move on a little bit further here and think about some of the kind of components to that data. I know, Carrie, you've mentioned this and the others on the panel today. It's not just about procuring this data, right? And we have some autonomy to understand which data elements we need as we navigate through some of these changes. But then the next step, even as we saw CMS outline, was the analysis of the data that we have. So we know it starts by first organizing the data and then understanding that not just at the highest level, perhaps population level, which empowers you to make some strategic decisions, but really needing to get granular with that data to make those member level clinical decisions to drive overall success. So Dr. Jane, back to you and kind of the notion that you mentioned just a minute ago around innovation and making micro innovations to lead to something that's much more macro in scale. When you look at this slide here, do you agree with these components? And maybe you can help us understand a little bit more about the integral role that data interoperability, perhaps organization thereof, and integrity really plays with achieving success in all of these new initiatives.
Yeah, it's a great question, Emily. I think there's no doubt that data is clearly incredibly important. And there's also no doubt that we are data rich, but we are information poor, meaning that we spend an enormous amount of energy collecting data. And sometimes we do it really well. Sometimes we use Scotch tape and baling wire to collect that data. And we assume that just by throwing it into a pot and stirring it around a few times, that we can get some very useful information. But the reality of it is that we actually have to spend some time and energy trying to figure that out. Just knowing that Mr. Smith, who walked through the emergency room door, is the same Mr. Smith that got admitted to the hospital, is the same Mr. Smith that I saw in the exam room in the clinic, is a very tough challenge. That the lack of having a common patient identifier, again, it's actually against the law to have a unique patient identifier for every American. We have to use other methods to figure out who's who in the zoo, if you will. The various types of data that you see off on the left that we all believe is important at varying degrees to understand what's actually happening to an individual. Remember, vital signs, traditional vital signs and physical examination might only determine 30% of my overall well-being. The rest of it is my habits and my environment and a variety of factors around my consumer behaviors and things of that sort. Well, what language are we going to use to communicate those things so that when we bring all that data together, it's going to be apples and apples instead of apples and oranges? So true understanding, labeling, standardizing this data, making sure we know who the individuals are, whether we have member IDs, patient IDs, multiple MRN IDs, that's an incredibly important part of really being able to take advantage of this data, to the point where it's important to find mechanisms, partners, solutions, technology appliances, whatever it might be, to make the data piece of it a non-issue so that we can all focus on the insights that are being gathered from that data. What are the analytics that we're going to focus on that say that Mr. Smith, who just walked through the emergency room door, he is someone we should be sending home versus admitting to the hospital in order to make sure that they're optimally managed. And if we do admit them to the hospital, what can we do to make sure they don't get readmitted to the hospital? These are things that should never happen. And so really the focus on data is important, but finding the right partners who have already solved the first mile and the second mile of the data so that we can all focus on the last mile of the analytics is a really, really important piece. And certainly what Innovaccer has been focusing on. And before I joined Innovaccer, what my prior company was focused on. And prior to that, what my other companies were focused on. It's been a long journey, and we're getting better and better at it each and every day. But the real goal is to shift the equation from spending 80% of our time cleaning up data, harmonizing data, and only 20% on the real work, and spending 20% of our time cleaning up data and harmonizing it so we can spend 80% of our efforts collectively on really changing the outcomes for our patients. That, I think, is really the value of having partners who can really understand the data and make it more usable.
Yeah,
Does that make sense?
fantastic. Yeah, absolutely. And so a couple of things that I think we can take away from your thoughts there is how do we get really good at what we're seeing on the left-hand side, bringing all of these data elements together so that we can spend our time and focus on understanding how we push out those insights into the appropriate channel of care for that member and where that member or patient needs to be met. And you said something that I think we all aspire for, and that's how do you make data a non-issue so that we can shift that dynamic from 80-20 to 20-80, perhaps. So when we think about all of these data elements, and we've identified here, all of our panelists have identified that data is definitely crucial for thinking about, again, navigating this change. Have another poll for our audience here. And what we'd like to understand from our audience members is when you consider these elements and their importance for navigating STARS, health equity, cost equity, et cetera, cast your vote for which of these pillars that you see here on your screen. Which do you have the most interest in? Which do you think are most important, again, for navigating through this change? You can use the QR code, again, on the screen. There's also a link within the Zoom chat, but oh my gosh, they're all equally important. I love that. Okay. We'll give everyone a minute or two here to cast their vote. Just to note here, some of the key things we've called out are provider engagement workflows to close gaps, FHIR-enabled data pipelines, integration with pharmacies to create additional touch points, HEDIS IDSS reporting, NCQA certified measure engines. There's certainly a whole plethora of other data related items here. So we have a few. Appreciate your thoughts. We'll give everyone just a couple more minutes here to cast their vote. Right. Okay. I think we have it. The results are in. I think our audience is most interested in thinking about provider engagement workflows to close gaps. And a second there is really around definitely more of the technical IT side, the FHIR-enabled data pipelines, and how do we make these things interact with each other seamlessly. So I think we appreciate everybody's participation. I think that makes a lot of sense. And that goes back to what Dr. Jane was just saying. How do we refocus our efforts on the right-hand side of that screen earlier and thinking about which of the touch points at the right time is most appropriate for the patient? It sounds like that's what everyone here is focused on. So Kara, would love to hear Longevity's thoughts on provider, care gap closure, any of the other technical items that we saw in our poll today. So if you don't mind sharing maybe a little bit about how your organization is working to make data a non-issue, thinking about closing some of these provider care gaps and those data requirements, and taking advantage of these kind of top priority tools for Longevity's success in this enhanced environment.
Thank you. The slide that you're seeing here is just a little bit about longevity because a lot of people are not familiar with special needs plans for the institutionalized members. So this is really just for your information. You can see all the colored states are where we have health plans. Each state has a different H contract. So I have a lot of H contracts to be monitoring. And each state is uniquely different. I cannot say that what works in Wisconsin is going to work in Florida. It is completely different. And so in order to really understand where our opportunities are, where our members are, I need data. And as I said earlier, I thought it would be wonderful when I came to longevity. I would have access to all of this data. Well, I do have access to all this data, but it's over here and over here and over here, and I don't have that one look. And how do I feed this data to my providers? I saw in the chat that someone had asked a question about if I think that applying health equity to risk adjustment risk scores will strengthen the focus on health equity for quality. And yes, I do. When for years years ago, quality was just something that you did. There was no money behind it. And so the more you can get where there's money behind it, you're gonna get traction with your leadership to be able to implement what you need to move the needle. And now we've got health equity really impacting two programs that have money behind it. So I really think we finally may have the gumption to move forward and get this done. I actually happen to have part of health equity underneath me as well as quality. So for me, it's really nice. I have been working with Innovacer since I came to longevity, and I'm really excited about the tools that we're working on together. We're validating our data literally down to the measure so that I feel comfortable with that data. They are an open box. It's really helping us to understand. And the next step is really going to be how do we integrate that data and get it out to our practitioners so it's in a usable format for the practitioner to be able to take action. So that's where I'm excited about and how we're tackling all of these various data sources that are out there.
Fantastic. And thank you for answering the question in the chat, Kara. Absolutely. And I think, what we're seeing and finding here is something that's not new. When you align incentives, you can make incredible progress. And that's exactly what CMS is looking to do is to align incentives across the board. So really appreciate your insights and giving us a sneak peek underneath the LHP hood there. All right, so we are running out of time. This has been an incredibly rich discussion. So thanks again to all of our panelists today and to the questions and polls, surveys that have been completed. We appreciate it. So I think a few kind of key takeaways, perhaps at a high level, and then I'll ask our panelists for one kind of final thought. So we've learned the why. Again, going back to understanding individualized member healthcare and how do we bring health and cost equity together. We've really kind of double-clicked on the fact that data is integral in success. We have a template. That's just a starting point. We need to understand what all we need as an individual payer, health plan, clinician, et cetera, to kind of create this holistic picture and view for each and every member that we're servicing. And then we're going to refocus our efforts and hopefully spend more time on not just cleaning, scrubbing, and organizing data, but using that data for actionable insights to truly drive healthcare outcomes. So with that being said, Dr. Jane, I'm going to call on you first here. If there's one perspective, one kind of nugget you'd like to leave with our audience and viewers today. I'm going to use this slide to kind of give you some inspiration in your response here as well. This is a view of the quality solution that we here at Innovacer have recently launched here just this week, actually, within the marketplace. What's the one nugget you'd like to leave our audience with today?
I think I would just remind everyone that healthcare is complicated. And what we're trying to do with these programs, and I love the comment earlier about where there's incentives, there's behavior change. We just all have to work together to make sure that the incentives actually cover the costs of the behavior that we're asking to change. And that requires us to be involved in the process. It requires us to be measuring and monitoring and doing continuous improvement. I love the comment. I mean, our philosophy at Innovacer around we want to do year-round quality reporting. Quality reporting should not be seasonal. It's not like giving a flu shot. It is about continuous process improvement. And I would encourage all of the audience members who are interested in our philosophy around how we're approaching this to go visit the material that we have laid out. I think that's probably the most important thing is that it requires partners. It requires expertise. And it's a journey. It's not going to happen overnight.
Fantastic. Kara, anything you would like to add to that?
Yeah, just that I think this is a really exciting time for those of us who work in quality. We've been waiting for this for years, and we're finally seeing it come together. And having tools that can really pull the information all together is critical in this journey. But I'm excited. I think that there's going to be some major changes coming, and it's good. It's good for our members, and it's good for us.
Fantastic. Agree. All right, Nate, what do you think? What's our one parting piece of wisdom here as we bring this to a close?
Yeah, I'll try to keep it short and sweet, although I agree with Kara, quality, we're finally getting our moment here. The organizations that are going to succeed at this are the ones that invest in connecting the dots. So to Dr. Jane's point, healthcare is complicated. It's always been complicated, but now that you're required to focus on all of these things, right, it's even more complicated. It's not something that you can shove under the rug or just kind of focus on whoever's falling around average for you and say, well, we can get most of our quality performance checked off the box there and ignore these people that are living out on the edges. So the organizations, whether it's through a solution like this or cross collaboration kind of across all of the verticals that support quality within your organization, sharpening up your elbows, right? And getting in there and saying, we will not succeed unless we consciously connect the dots here and start working together. Yes, that's always been important for organizations that succeed in quality, but now more so than ever is the only way that you will get this done in a way that you can sustain over time.
Yeah, absolutely. Love it. Collaboration. It's kind of where we started that roller coaster. If we think back to that slide, funny how we wound up right back there, but in a little bit of a different way. So thank you very much. I know we've run out of time. So if you would like to stop by the Innovacer booth or hear from any of our panelists, we would love to meet you if you were able to attend our webinar today. We will be at the Rise Qualipalooza next week in Atlanta. Feel free to scan this QR code. And there are lots of QR codes as we make this webinar available to all of those that had registered today. So if you're in the area attending Rise Qualipalooza, we would love to see you. And then last but not least, just thank you very, very much, Kara, Nate, Dr. Jane, for all of your inspiring thoughts on really how we can think about moving forward, our approaches to success as we navigate these changes in STARS. A huge thank you to our audience for spending some time with us and participating in our polls today. Again, this deck will be available to all those that registered, so feel free to use those QR codes for any more information as you've been able to see throughout this presentation. Thank you again very kindly. Take care all, and we will see you soon.
Thank you. Bye-bye.
Thank you.
Thank you.